We are going to present the following challenging case, aniridia and cataract of traumatic origin in a patient with a posterior chamber phakic intraocular lens, surgical strategy. The authors have no financial interest in the products presented in this video. The case is a 38-year-old woman who underwent surgery for hyperopia in both eyes in 2018 with a posterior chamber phakic intraocular lens, ICL star surgical, and who suffered trauma with a blunt object in the right eye in 2021. On examination, you can see a normal central cornea with a closed superior corneal incision and aniridia, an hyperopic ICL located in ciliary sulcus, and a posterior subcapsular cataract with a stable sonul. So, at the time of trauma, the iris came out through corneal incision and the ICL avoided the crystalline lens luxation. To resolve this case, a two-step surgical strategy was established. In the first step, the ICL explant, femtosecond laser-assisted cataract surgery, and the implantation of an extended focus monofocal lens would be carried out. In the second, the artificial iris from HumanOptics would be implanted in the capsular bag. Before starting the first surgery, the absence of the iris, the phakic lens, the femtolaser capsulotomy, and the posterior subcapsular cataract can be seen. What was done during the surgery was the following. Mark the steep and flat corneal meridians, in this case assisted by a digital system of image analysis. Perform the corneal incision in the steep meridian. Inject the cohesive viscoelastic above and below the ICL. Explant the ICL through a 3 mm incision with a capsulorhexis forceps. Remove the anterior capsule. Perform microdissection with a 1% lidocaine. Remove the cataract using the 2.8 mm coaxial irrigation aspiration handpiece. Implant the rectangular section capsular tension ring with Kellman-McPherson forceps. Clean the 8 cells of the anterior capsule with a Whitman-Shepherd capsule polisher. Implant the extended focus monofocal lens in the capsular bag. Remove the viscoelastic from the anterior chamber and the capsular bag. And finally, rotate and center the lens. At the ends of the surgery, a completely clean capsular bag and the lens haptics resting on the capsular tension ring can be seen. 3 months after surgery, we have a stable capsular bag, a very clean capsules, and the lens haptics supported on capsular tension ring. The anterior segment OCT shows the correct position of the lens pack complex. At this time, the DCBA was 1.0. 6 months after cataract surgery, artificial iris implantation was performed when the capsular bag was completely healed. The steps of the technique are as follows. Mark the main corneal meridians. Measure the capsular bag with a strabismus compass. As we can see, the horizontal diameter is 10.0 mm. Perform 3 auxiliary paracenteses. Inject cohesive viscoelastic. Open the capsular bag with a blunt spatula using the 3 paracenteses. Take the custom flex artificial iris, fiber-free, out of the container. Select a 9.5 mm trephine. Cut the artificial iris to the desired diameter. Place the artificial iris in an ICL cartridge. Perform 3 mm corneal incision. Inject the artificial iris into the anterior chamber. Make a radial cut of the iris with Vanna's scissors. Put the iris inside the capsular bag, slowly, with a rotational movement similar to that performed when the capsule ring is in implantation, avoiding, in the possible, traction on the capsule or sonol. And finally, remove viscoelastic from the anterior chamber. At the end of the surgery, the artificial iris can be seen inside the capsular bag. No intraoperative complications occur. The capsular bag is stable, completely healed, with the capsular tension ring, the intraocular lens, and the artificial iris inside. Functional results are also very good, with an UCVA of 1.0 and with the focus curve showing good intermediate and near vision. And finally, the patient is very satisfied with the aesthetic results obtained with selected iris color. Regarding the discussion of the case, we would like to make a brief comment. In a highly recommended article published in 2017, Meyer et al. Describes 7 possibilities for implanting a HumanOptics artificial iris based on iris injury and capsular bag viability. The patient we present corresponds to option C described by the authors. As we can see, it is a rare situation, and its main risk is a rupture of the capsule or the sonol during artificial iris implantation. In our patients, there were no complications in either of the two surgeries. In conclusion, the traumatic aniridia without lens subluxation should be treated with two-step surgical strategy. The surgical technique proposed for cataract surgery in the first step achieves a stable capsular bag that facilitates the implantation of the artificial iris in the second step. Thank you for your kind attention.